About one-third of the world's population is infected by Mycobacterium tuberculosis. Between 7 and 8.8 new cases occur each year, 95% in developing countries. Some 3.3 cases of tuberculosis are notified each year. Projections into the next century suggest that the impact of tuberculosis will increase, if no adequate control is established immediately in all countries. The overall objective of tuberculosis control is to reduce morbidity, mortality and transmission of the disease until it no longer poses a threat to public health. To achieve this objective, the 1991 World Health Assembly endorsed the following targets for global tuberculosis control. Successful treatment for 85% of the detected new smear-positive cases, detection for 70% of smear-positive cases by the year 1000. Surveillance of tuberculosis helps to monitor the course of the tuberculosis epidemic, and patient cohort analysis is used to evaluate treatment outcomes. The objective of TB surveillance is to provide timely, ongoing and systematic collection, collation, analysis, interpretation and dissemination of information in order to monitor disease trends, for example incidence of disease, geographic and risk group distribution. Estimate future disease impacts, plan, implement and evaluate interventions and preventive programs in order to reach performance targets. Inform the development of health policy and resource allocation. Assist in setting standards of care and practice guidelines. Identify research needs. Surveillance is the ongoing systematic collection, analysis, interpretation, and dissemination of data about a health-related event. Is a critical component of successful TB control, providing essential information needed to do the following. 1. Determine TB patterns and trends of the disease. 2. Identify sentinel events, such as potential outbreaks, recent transmission, multi-drug resistance, and deaths. 3. Identify high-risk populations and settings. 4. Establish priorities for control and prevention activities. 5. Strategically plan the use of limited resources. Although health departments share TB surveillance data with CDC, the responsibility and authority for TB surveillance rests with the health department. States vary in the structure and organization of their surveillance systems, and often in the completeness or quality assurance of their case reporting. As with any reportable disease, the completeness of TB reporting reflects how actively health departments solicit case report information. Historically, disease surveillance systems have been categorized as passive or active. Passive surveillance: health departments passively receive case reports from healthcare providers, depending on the healthcare providers, to know and comply with reporting requirements. Active surveillance: health departments actively contact and interact with healthcare facilities or individual providers to stimulate disease reporting, sometimes directly assuming the primary responsibility of reporting cases from large or high-volume institutions. The importance of reporting TB cases is for increased ability to assess program performance, completeness of data collection, and accuracy of reporting. Improved data for program planning and policy development, for example personnel, resources, funding. Facilitation of patient services, for example quality of care, continuity of care, sharing of accurate information with patient and health facilities. There are two ways to report TB cases, which is reporting or confirmed case of TB in hospitals and acquiring report from the local public health. WHO recommended surveillance standard. Recommend case definition. Primary drug resistance is defined as the presence of resistant strains of M. tuberculosis in a patient who, in response to direct questioning, denies having had any prior anti-tuberculous treatment or for whom, in countries where adequate documentation exists, no documented evidence of such a history is found. Acquired drug resistance is defined as the presence of resistant strains of M. tuberculosis in a patient who, in response to direct questioning, and admits having had prior anti-tuberculous treatment or for whom, in countries where adequate documentation exists, documented evidence of such a history is found. Category of patient is required. Recommended types of surveillance for TB. 3 main principles must be followed. 1. Use of a data collection system based on standard registers for all tuberculosis patients, designed in such a way that new patients are distinguished from those previously treated. National tuberculosis programs using the WHO tuberculosis control strategy adopt a recording and reporting system, which allows this kind of differentiation. 2. Use of laboratory methods internationally recommended for susceptibility testing. A country should have no more than one national reference laboratory (NRL), to which diagnostic centers send the sputum, with the exception of very large countries. The national reference laboratory should be linked to an international laboratory by strain exchange to ensure quality control. 3. Adequate sampling strategies must ensure the representativeness of the country or area to be surveyed. In general, countries can choose between routine surveillance and ad hoc surveys at regular intervals 3 to 5 years according to the availability of resources, logistics, and to other operational considerations. Recommended minimum data elements. Peripheral level diagnostic centers: patient identifier, age, sex, specimen date, history of previous treatment, other data, nationality, HIV status if known. Only patient with positive sputum smear S should be enrolled. National Reference Laboratory anti-tuberculous drug susceptibility test results. Central data from the diagnostic centers and from the National Reference Laboratory should be matched and analyzed by a coordinating team. Principal uses of data for decision-making. Monitor levels and trends of anti-tuberculous drug resistance prevalence, as an indicator of the effectiveness of tuberculosis control efforts. Identify outbreaks of multi-drug resistance in certain settings. Provide feedback to those regions or areas which participated in region representative surveys. Under special circumstances, review the policy of tuberculosis case management. 27 August 2015 Geneva missed and delayed diagnosis of tuberculosis TB can result in poor health outcomes for the affected individuals, catastrophic costs for their families, and continued transmission of TB to others in their communities. Systematic screening for active TB among those at the highest risk can complement other efforts to improve early detection and treatment of TB. WHO has issued an operational guide that provides practical advice on how to develop a national or local TB screening strategy. To further aid the process of prioritizing high-risk groups for screening and chose an appropriate screening and diagnostic algorithm, an e-tool Screen TB has been developed, which helps estimate screening yield and cost of screening. 29 September 2015 Amsterdam. The WHO Global TB Program and the European Respiratory Society (ERS) today launched a new agenda for action to harness the power of information and communication technology to end TB. Tuberculosis TB is a serious global public health threat. Million people falling ill that year. New information and communication technology presents significant opportunities to combat this disease on various fronts. The agenda highlights strategic directions to integrate digital health into TB prevention and care activities in support of WHO and TB strategy. We need to think digital in our push to end TB, said Dr. Mario Ravaglian, director of the WHO Global TB Program. Information and communication technology are powerful tools, and will be vital in helping us reach our ambitious new global targets in both low- and high-income settings. Digital Health for the End TB Strategy and Agenda for Action advocates that TB programs, other national authorities and all stakeholders integrate digital health solutions in their implementation of the End TB strategy. Information and communication technology can help advance patient care, surveillance, program management, staff development e.g. e-learning, and the engagement of communities. Guides programs on promising options for first focus of efforts, building on the limited available evidence about the effectiveness of digital health interventions for ending TB. Promotes continued monitoring and investment in implementation research on digital health interventions, to increase the evidence base on effectiveness and impact. Tuberculosis outbreak. Definitions for TB outbreak are relative to the local context. Outbreak cases can be distinguished from other cases only when certain associations in time, location, patient characteristics, or Mycobacterium tuberculosis attributes become apparent. In low-incidence jurisdictions, any temporal cluster of cases is suspicious for an outbreak. A working definition for a potential TB outbreak is helpful for planning and response, and may include any of the following 6 criteria. A TB outbreak may be suspected on the basis of information from diverse sources, including TB case reports, contact investigations, routine surveillance, and genotyping data. Because of the possibility of uncertainty as to whether an outbreak has occurred, it is helpful to define some initial activities, which can be put into place while seeking additional information. This will include convening an outbreak team, to determine if this is an outbreak, as well as ensuring mechanisms are in place to respond. Exceptional TB circumstances. TB transmission has its unique set of factors. As a result, not all situations under an outbreak criterion will merit the same amount of scrutiny and consideration for an outbreak response plan. Exceptional TB circumstances are defined as situations that merit additional scrutiny and discussion, but are not specifically addressed in the above criteria for TB outbreak. An exceptional TB circumstance may prompt initiation of the outbreak response team or, alternatively, an exceptional TB circumstance may be resolved by standard program operations. The following are examples of exceptional TB circumstances. A patient with infectious tuberculosis is suspected, or known to have Mycobacterium tuberculosis resistant to at least rifampin. Persons with HIV infection or other immune-compromising conditions are suspected, or known to be exposed to a patient with infectious tuberculosis. A child 5 years of age or younger is confirmed to have tuberculosis, for which a source of infection is not discovered after an investigation. An increase in the number of cases over time in a particular area is considered significant by the tuberculosis team. Extensive TB transmission is confirmed or suspected. These situations may involve workplaces, schools, unconventional social networks, or other circumstances in which screening for TB disease and infection involves a large number of people, or in which multiple cases are suspected. The ultimate goal of TB outbreak response is to interrupt ongoing transmission of tuberculosis. An outbreak generally involves multiple TB cases with several overlapping contacts. Compared to TB contact investigations, responding to TB outbreaks requires many more resources, a larger and more diverse group of partners and stakeholders, and more extensive collaboration and communication. TB outbreak response is a process used by public health programs to investigate and intervene when a TB outbreak is suspected or confirmed. Timely detection of TB outbreaks is a fundamental component of TB prevention and control. Detecting signs that suggest an outbreak may be occurring is important, because a rapid response can help control and minimize outbreaks. During these activities, health department workers should be alert for signs of more TB cases than expected and evidence of recent transmission among those cases. Outbreaks can be detected through the following activities, which is observations from health department staff and others in the community. TB contact investigations, TB case surveillance and TB genotype surveillance. Malaysia has witnessed decades of good TB control. However, a recent increase in new cases among the general population has fueled concerns that this trend is linked, in part, to higher rates of TB in crowded settings, including prisons. An aging population, plus large numbers of immigrants, is worrying health authorities in Sabah, which already has the highest number of tuberculosis cases in the country. About 30% of TB patients in Malaysia are from Sabah. Sabah Medical and Health Services Department Senior Assistant Director Dr. Richard Avoy said many of the TB patients in Sabah were foreigners. Our population is also getting older. Those above 60 years face higher risks as their immunity is weaker, he said at a seminar on TB organized by the Sabah Anti-Tuberculosis Association Sabata here. Dr. Richard said diabetics were also at risk, as they were 2 to 3 times more likely to contract the disease. We need to do more to lower the incidence of the disease in Sabah. We need more manpower and resources, as this is a large state. While the department had intensified its detection efforts, resulting in more of those with the disease being treated, Dr. Richard acknowledged that there were some who could have been missed out. Over a 6-month period, the researchers asked all HIV-infected as well as a comparative group of HIV and infected prisoners at Kajang Prison, to participate in tubercle and skin test surveys, that included questions about previous incarcerations, history of TB disease and previous illicit drug use. Overall, they found that 88.88% of all prisoners had been exposed to TB, which represents the first empiric data in this population. The team has also found similar rates among prisoners in Penkalan Cherpa prison in Kelantan state, confirming a high rate of TB exposure among the incarcerated population of Malaysia. When infected prisoners are released back into society, they may spread the disease among their community and the general population, which may be one of the factors responsible for increasing rates of TB. According to the researchers, the high prevalence of TB in these samples suggests that evidence-based TB control programs urgently need to be implemented in Malaysian prisons. Such programs could have a positive impact on the overall rates of TB, not only among prisoners but also in the general population at large. Kuala Lumpur, January 15. Tuberculosis TB is fast rising as a non-communicable disease NCD in the country, with a death rate even higher than that of dengue. A total of 1,250 deaths from TB were recorded in 2012 compared to 34 deaths from dengue in the same year. Even the number of TB cases were higher than dengue. Thank you for listening.
Hello friends, do you have any questions regarding TB surveillance and outbreaks?
Yes. What are the objectives of TB surveillance?
Okay, the objective of TB surveillance is nothing but is to monitor how TB can be actually stopped and how can you actually get the notifications so that you can prevent the disease before it gets to death. That's all.
I have a question. What do you think will be the surveillance for tuberculosis?
Okay, currently there are a few main points that I would like to highlight here done by the WHO. Okay, they have actually issued e-tool for screening for TB. E-tool in the sense that it is easy for them to use the media in order to propagate information regarding TB, the awareness regarding TB. Another one is again something to do with media as well. On 29 September 2015 in Amsterdam, they have used the information and communication technology to reach out to the public regarding the screening. That they're doing screening over here, please come and join. I'm doing screening over here, please come and join, and they are to the target population. Okay, so this is the most famous surveillance right now.
Alright.
And how TB outbreak is detected?
Come again? Didn't get
How
you.
TB outbreak is detected?
Oh, outbreak. Okay, how TB outbreak is detected is very simple. If you have few steps on it. Number one, observations from health department. Okay, you go to the health department and you observe what are the current cases, how many cases have been reported. Okay, and then TB contact investigators. Okay, you go and investigate the TB contact. Next is TB case surveillance. Okay, you go to the surveillance team and then you can ask information regarding the outbreak. And last one is the TB genotype surveillance. Any other questions, class?
I don't think there's any more.
Alright, thank you so much.